something that I really enjoy.
I've been working at Southend Hospital for about 2.5 years now. I started on a rotational post. My first post was on oncology, where I worked with terminally ill patients and helping meet their needs. I then moved to orthopaedics, where I worked primarily with patients who had hip fractures. And then I moved to neuro, where I'm now a senior, and that's where my passion lies. I think working for Southend Hospital is ideal for a lot of occupational therapists, just because we have a wide range of rotations here, for example, peds and neurology. And I think having that wide range of rotations allows you to use and develop a wide range of skills. Everyone here works really well as a team, and we all just look after each other. So when we have new stroke patients on the ward, they need to be seen by occupational therapy within 72 hours. And at least one member of the rehab team needs to see them within 24 hours. Each patient that's had a stroke is seen for 45 minutes of rehab a day, 5 days a week, and on weekends when we can. And in addition to that, we always set goals with the patients that are patient-led, and they are set within 5 days of the patient being admitted to the ward. Our role as an occupational therapist is to increase a patient's independence in whatever way we can. When they first come to the ward, we need to assess them from a neurological point of view, so we'll be looking at things like their sensation and their coordination and their muscle strength. We need to assess whether or not they have sitting balance, what sort of seat would be appropriate for them, do they need a special wheelchair. We also need to consider the functioning in their upper limb. Another important part of an occupational therapist's role is to look at their cognition, so looking at things like their attention, their memory, their perception. We also need to create programs, so we have upper limb programs, cognitive programs, which include process training, functional training, strategy training, education. Obviously there's quite a focus on practicing activities of daily living, because as an occupational therapist you need that patient to be as independent as possible. We also get involved in assessing a patient's home to know if it's appropriate for them to go home, and assess what equipment they might need in order to maintain safety at home. We get satisfaction from our patients. In rehab, we're well known for getting excited about the smallest improvement. So if someone's finger twitches on an arm that wasn't moving before, or the first time a patient is able to feed themselves their breakfast with a spoon, or the first time they manage to successfully find their way back to their bed on their own without me telling them where it is, or when they're able to make a cup of tea when there's a lot of distraction going on, those things really get us excited in rehab. A symptom I find particularly rewarding in rehabbing with stroke patients or brain injury patients is apraxia. So for example, sometimes they may no longer know how to use an object, so they can't feed themselves, they can't wash themselves, they can't do anything because their brain no longer helps them to use those objects appropriately. So with functional repetitive practice you can make a lot of headway with that symptom. For example, we had a patient who had quite a severe dressing apraxia, so when he looked at items of clothing it was like he'd never seen them before. But with a lot of functional practice and use of strategies like looking in the mirror, by the end of his stay here he was able to successfully dress himself. One patient I really enjoyed working with was a patient who had Guillain-Barré syndrome. She came to us after a long stint on ITU. And I remember her saying to me that she was so weak that she tried to move the hair out of her face, but her hand wasn't strong enough to move the hair from her face. And by the time she left us to go on to further specialist rehab, she was able to wash and dress her top half, she was able to feed herself, she could comb her hair, and she was standing in rehab with the help of 2 or 3 of us at a time. We had a teenager that came to us following a traumatic brain injury. When she arrived here, she couldn't show any emotion, she didn't have a sense of humour, she couldn't plan for herself, she couldn't problem solve. She struggled to initiate any kind of action, so if you put food in front of her, she wouldn't eat it. So she was really suffering when she got here. By the time she left, she started a graded return back to school. We've been given £1 million investment to help develop into a hyperacute stroke unit. So that money can be used to increase our staffing and to increase our resources. And the larger team we have, the greater skill set we have, so the better for us because we can learn from them, and the better for the patients because they get better all-round care. The stroke unit offers weekly in-service training for all staff, and in addition to that we also have senior workshops. The other really good workshop that we run here is for complex patients. So as long as the patient consents, we'll have a workshop with 1 or 2 patients, and together we'll all problem solve the best way to treat that patient. So it's a really good learning opportunity. One of the best things about working on this stroke unit is the frequency of joint working. So on a daily basis you'll work jointly with a physiotherapist or a speech and language therapist depending on the patient, and I think when you do that you become more aware of all aspects of the patient care and the patient's rehab, and that helps you provide a better service for the patient, and it's much better for your learning as well.